Hi, I'm Dr. Tom Buchholz. I'm a radiation oncologist, and I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, California. I welcome you to our discussion of breast cancer cases today. We really have an outstanding multidisciplinary panel, including breast surgical oncology, breast medical oncology, breast radiation oncology, and breast imaging or breast radiology. And I'd like each of our panelists to please introduce ourselves. Let's start with Dr. Mamounis, our breast surgical oncologist.
This is Terry Mamounis. As Tom mentioned, I'm a breast surgical oncologist, and I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute in Orlando, Florida.
Thank you, Dr. Mamounis. Dr. O'Shaughnessy.
Hello, everyone. I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center and the Chair of Breast Cancer Research in the U.S. Oncology Clinical Trials Network in Dallas, Texas.
Thank you, Dr. O'Shaughnessy. Dr. Shaw.
Hello, I'm Chirag Shah. I'm a radiation oncologist at the Cleveland Clinic and serve as the Director of Breast Radiation Oncology and the Director of Clinical Research.
And the final member of our panel is Dr. Butler.
Hello, everyone. I'm Dr. Rennie Butler. I am Associate Professor at Yale University School of Medicine and Diagnostic Radiology, and I specialize in breast imaging.
Thank you, Dr. Butler. Our next case is a 65-year-old with early stage disease, a pathologic T2N0. This is an infiltrating lobular carcinoma. As most lobular carcinomas are, it's ER/PR positive and HER2 negative. There was a positive margin of LCIS. The actual invasive lobular carcinoma margin was 1 millimeter and negative. She had an Oncotype score of 32. So a question becomes, is re-excision for a positive LCIS considered? Is that warranted? Would chemotherapy be offered to this patient? And if so, which regimen? And would radiation be offered to this patient? So a little bit more about her history. She noted breast discomfort for about 3 months. She has no family history of disease. Medical history is really unremarkable. On mammography, she was noted to have a 2.6 centimeter mass in the right breast. An ultrasound confirmed this, as did an MRI. A biopsy was performed with a core needle biopsy revealing an invasive lobular carcinoma, ER/PR positive, HER2 negative. She underwent segmental mastectomy or lumpectomy and sentinel lymph node dissection, showing a grade 2 lobular carcinoma with a small focus of LCIS, ER/PR positive, HER2 negative. There was a positive margin with LCIS, but margins negative for an invasive cancer. There was one margin that was close at 1 millimeter. No involvement of lymph nodes, Oncotype score of 32. As we get started, Dr. Butler, can you describe the findings and also the unusual radiographic appearance of lobular carcinoma in general?
Sure. Invasive lobular carcinoma is notorious for being difficult to detect. And that can be true with regard to all modalities, starting with the clinical exam, where it can present with just some subtle palpable thickening rather than a discrete mass. The mammogram, where it tends to more commonly present with subtle findings such as architectural distortion and focal asymmetry, rather than the more conspicuous spiculated mass that we see with invasive ductal carcinoma, and right through to ultrasound and MRI in some cases. In this case, the ultrasound is clearly our best visualization of this mass, although if we compare the right MLO view to the left MLO view and try to appreciate them as mirror images, we can see that there is some increased density in the right upper breast that corresponds to this mass. But on the ultrasound, the findings are obvious. There is a irregular, very hypoechoic, almost anechoic mass with strong posterior shadowing. And we can see on the colored Doppler image in the center of the middle row that there is some increased vascularity in the adjacent region. This is often the case. The absence of vascularity within the mass itself should not deter us from assessing it as highly suspicious. Oftentimes, the greatest metabolic activity is seen within the boundary zone of the tumor, and the center of the tumor might be necrotic or paucicellular. The MRI here is a MIP image, which shows some increased areas of enhancement corresponding to the finding.
Thank you. So she underwent, as mentioned, a right lumpectomy, and we're going to ask the questions about additional surgery. Is it necessary? Terry, why don't we start with Dr. Mamounis? Do you consider LCIS as a component of margin? Do you consider LCIS in the setting of an invasive lobular carcinoma differently than just random finding of LCIS? And what would be your recommendation for this particular situation of her margin?
Right. So yes, I think that you just hit the nail on the head. I think in general, we view now LCIS as a precancerous condition, a high-risk lesion. If we diagnose LCIS alone, we don't care too much about the margins. We offer the patient, chemo prevention, or sometimes on rare occasions, even mastectomies, prophylactic. But in general, we treat it as a high-risk lesion. LCIS in the face of concomitant invasive lobular carcinoma may biologically be somewhat different. So I would be a little bit more cautious about a patient like this who has a positive LCIS margin and a close invasive lobular carcinoma margin on the other side. The LCIS was on the lateral and the other one was anterior superior for the close invasive lobular carcinoma. I mean, technically she has negative margins, but I would have a discussion with her about the possibility of actually performing a re-excision. It was a sizable lesion. On the MRI, it looked a little multifocal at least. So I would have that discussion because it's possible that she may have invasive lobular carcinoma on the site of the LCIS. But again, if she was adamant about not undergoing a re-excision, I would proceed with radiotherapy. I mean, I think it's okay. But I would be a little bit more cautious about a patient like that where the two different margins are close and involved, even with LCIS.
Dr. Shah, do you agree? Any other comments from the radiation oncology standpoint?
No, I agree with Dr. Mamounis. It's certainly concerning having a lobular carcinoma and a positive LCIS margin, certainly a discussion to have with the surgeon. In terms of radiation therapy, independent of the LCIS margin, in theory, this patient qualifies for Prime 2, which was recently presented in abstract form with 10-year outcomes, and that allowed women 65 or older with tumors up to 3 centimeters. I would counsel the patient that lobular cancers were pretty underrepresented in that study and may not be reflective in the recurrence rate. So I would probably favor radiation given the positive LCIS margin and the lobular histology. In terms of my preferred regimen, I would favor whole breast radiation in this case, something like 40 gray and 15 fractions. It should be noted in theory she is a candidate for partial breast based on current guidelines from the ABS and the ASBS, the American Society of Breast Surgeons and the American Brachytherapy Society, which allow for lobular cancers up to 3 centimeters. So that's in theory an option, but not the option I would prefer for this patient.
Would you consider that even with the margin question?
I technically wouldn't, though the guidelines do not consider an LCIS to be a positive margin. And so they basically state negative margins. I would be concerned. So I would still go with whole breast radiation and even consider a boost if that margin wasn't re-excised.
And you mentioned this Prime 2. I wasn't quite clear on the point. Can you talk a little bit more about that?
Yeah, certainly. Some folks may question whether radiation is needed at all in this patient. And Prime 2 looked at women 65 or older with tumors 3 centimeters less and randomized them to radiation or no radiation with endocrine therapy given in both arms. At 10 years, the addition of radiation did not improve survival, but reduced rates of recurrence very similar to what we saw in CALGB 9343 for 70 and older women. It's around a little bit over 10% versus around 1 to 2%. So the argument could be made that radiation is not going to impact survival and have only a marginal impact on recurrence. But I think that with this being lobular, which was underrepresented, and the LCIS margin, I would favor radiation.
In addition, perhaps maybe this, through our former discussion about oncotype, in addition with being a higher oncotype, as another potential predictor for a little bit increased, more aggressive local regional approach.
Absolutely, I would say so.
Dr. O'Shaughnessy, would you offer chemotherapy to this patient, and if so, which regimen?
Well, the 21 gene recurrence score, or the 70 gene signature, otherwise known as the mammoth print, they have to be taken in the context of the overall clinical pathologic variables. And there's a little bit of a disconnect here because we're told it's an intermediate grade invasive lobular cancer as opposed to a more high grade pleomorphic lobular cancer, because the recurrence score of 32 is high. And generally speaking, it's more highly proliferative. But what we've learned about the recurrence score recently is predominantly driven by the strength of the estrogen receptor expression. So one thing I'd want to look at is what's the percentage, what's the all red score for the estrogen receptor? How functional is that estrogen receptor? What's the progesterone receptor looking like? What's the Ki-67? And I want to sit down with the pathologist or talk to the pathologist and see, is this classical invasive lobular or is this more of a pleomorphic lobular cancer? So I have to kind of reconcile that. If I can't reconcile, if I still think there's discordance, then I will get another test. I might send a 70 gene signature and get that, because in general, invasive lobular cancers are not that chemotherapy sensitive, and I don't want to give her chemotherapy if this is a falsely high recurrence score. She's node negative, etc. So, but let's just say that she, it really was, the ER was not particularly high, and this probably is, maybe it's a little bit of pleomorphic variability in there, and this really is a high recurrence score, then I would treat her. I would recommend chemotherapy to her. Unfortunately, we know that even node negative patients who have recurrence scores over 25, they really, in spite of modern day chemotherapy, they still have substantial risk of recurrence. So I would talk to her about kind of an AC paclitaxel regimen, and then of course optimal endocrine therapy, which would be an aromatase inhibitor. The big 198 did, when they looked at tamoxifen versus letrozole in the postmenopausal mixed node negative and node positive population, they did show in invasive lobular cancer that tamoxifen was actually deleterious, in my view, in my reading of the data, not only inferior to an aromatase inhibitor, even in low Ki-67 invasive lobular cancer, but actually it looks to be deleterious. We also published a paper from the MA27 that looked at anastrozole versus exemestane, and in the ductal cancers, there was no difference at all between the two. Interestingly, in the invasive lobular cancers, the outcome was trending, not statistically significant, but trending towards inferior with the exemestane for disease-free and overall survival. And interestingly, exemestane is metabolized into androgenic metabolites, and lobular cancers have a great deal of the androgen receptor. So I try to stay away from the exemestane and the tamoxifen in the invasive lobular breast cancers, particularly the postmenopausal patients.
Very interesting. So in summary, I think the panel would recommend consideration of a re-excision, whole breast radiation, plus or minus a boost, particularly in the setting of considering the close margin and whether they had a re-excision. And then trying to reconcile again this discordance of Oncotype score, possibly ordering a 70 recurrent scored gene test to get further information to help decide whether chemotherapy is warranted for this patient, because it's unusual for lobulars to have this discordance.